Invite Dr. Ritesh Kakrania, difficulty faced in post RKIs. So, as all of you are aware, it's not just IOL power calculation, but it's a structurally weakened cornea, the RK cornea. So they have challenges of their own.
Thank you, AS, and thank you, Dr. Sushmita and Dr. Shreya, for getting me out of my hibernation. Let's go to 80s and 90s, where tons and thousands of young people in 20s underwent RK. Nowadays, we see few cases of post-RK cataracts here and there once in a while in our OPD and OT, but probably we are staring at a tsunami because these patients are in early 50s. So we should be prepared for these patients who have undergone RK in 80s and 90s to come for their cataract surgeries. So that is the reason this talk is important. And I would acknowledge Dr. Uday, Dr. Deepak, and Dr. Abhijit for sharing their wonderful videos so that we can all learn better. Planning a cataract surgery post-RK requires a preoperative planning, a wonderful surgical execution, and fulfillment of refractive expectations of the patient. So pre-op evaluation includes noting the best corrected visual acuity so that that can be told to the patient during the counseling time so that the post-surgery hassles decrease. When you do a slit lamp, you calculate the number of cuts, and it is important. I'm going to tell you why. Also look at the depths of the cut and note the point where you feel that the cuts are less deep. We all know that RK would lead to about 90% of the corneal thickness. The depth of the RK marks are almost about 90%, in some cases little more than that. But look out for the areas which are less deep cuts, where when the number of cuts are much more, you can plan your surgical incision at that point. And topography for incision planning, if it is feasible, always do a corneal topography for incision planning. Counseling regarding the intraop complications and possibility of post-op surprises. With the Barrett-Truquet formula and ACRS calculator, even post-RK calculation is almost accurate. But in case you are not able to access these, then traditional method of adding 1 diopter to 4 cut RK, 1.5 to 8 cut, and 2 diopter and for 12 cuts and beyond still holds okay. The astigmatism doesn't change. So you have to, in the counseling, you have to promise the patient that the spherical would be as near as 0, but the cylindrical value would not change unless they opt for toric. Avoid peribulbar anesthesia unless it is not feasible. Avoid doing pinky or massage because you're going to press the RK and they might give way. Mark the incision sites. Use MVR instead of lance tip because MVR you are going to make only 0.9 millimeter of incision, so it's little well controlled. If it is an MVR, you can cut and pass and go very near to the RK cuts. So MVR is preferable. Phaco setting during whole surgery, during your trenching, nucleus division, irrigation and aspiration, the fundamental is to keep the infusion pressure to around 50 to 60 millimeter of mercury rather than 90 or 100. While implanting the lens, inflate the bag. Do not overinflate the anterior chamber with OVDs because they might cause the intraocular pressure to rise and the RK cuts may just daze. We can implant IOL in with 2.2 microincision or 2.8, but remember, if the IOL is thicker, if your IOL power is nearing say 28, 29 or 30, these lenses are much thicker. So we must pay an attention and should not struggle implanting these lenses through a microincision. It is better to increase the incision size to 2.8 to deliver these IOLs. While hydrating, hydrate vertically. It is better to avoid side hydration. We don't want to include side hydration going into the RK site. So the first video where so this is an 8 cut RK with when we are planning a cataract surgery, and it's always better to mark the side port site with a Sinsky. So one mark is done. the second one, and the main port, so that you can visualize. It is always better to stabilize the globe so that you have a control entry into the anterior chamber. Always make sure that you control the globe so that you have a very nice control. And the main site, 8 millimeter, 8 cuts, you can still go clear corneal. More cuts, it's better to hit the sclera. Rest of the technique remain the same, except the infusion pressure should be maintained to a low level. Once the surgery is over, it is important to check whether these RK cuts have not given way. So two techniques are to put a large air bubble and keep pouring water and try to find out these bubbles emanating, like what we see in tire punctures. And the second technique is to, after completing the surgery, stain the ocular surface with sterile fluorescein and then look for a leak, like rivulet, as we see in wound leaks. So once the surgery is over, the sterile fluorescein strip is smeared all across the cornea to look out for any leaks. Despite taking all these precautions, sometimes, particularly in very large number of cuts, we might face this problem. It's a wound adhesion, the RK cut has given way. In this scenario, you have to stop doing the surgery and first close the RK wound and then complete the surgery. It's not difficult, and the suture can easily be removed after about 3 to 4 weeks. Regarding the choice of IOL, it is important to understand that multifocals would have unpredictable outcomes. So what we can plan is a monofocal, a toric monofocal EDOF or a toric EDOF in such cases with wonderful outcomes. Post-op consideration, initially there would be hyperopic shift because of swelling of incision, which might last for about, this hyperopic shift might last for about 6 to 12 weeks. Do not decide to redo the surgery or break this news to the patient. Keep looking for the endothelial density, because these are high myopic cases with impaired corneal integrity from RK. And post-surgery refractive surprises can be tackled by spectacle RGPs or IOL exchange.